I am truly honored to join you in celebrating Shri Sitaram Jaipuria, and I am thankful to the Sitaram Jaipuria Foundation for your contributions to the medical and healthcare in India. It makes me nostalgic, obviously, having been brought up in Jaipur. And we have Dr. Shiv Sareen, who was 4 years ahead of me in medical school, and I have idolized him all my life, followed his trajectory all through. The only difference was that I went to cardiology and not in gastroenterology, but it looks like that our paths are crossing now. 2015, I visited you when there was a Cardiology Society of India meeting here. And he was pushing me at that time. I was doing my CT angiography studies, and we had done about 3,000 patients, followed them for 10 years, established the recommendations as to what exactly we should be doing with CT angiography. And he pushed me that I should be looking at the CT angiography in the patients with fatty liver disease. Somehow or the other, I don't think that I took it so seriously. And am I 10 years behind? Probably yes. But now coming to cardiology, we have another stalwart here from the same batch, Dr. Kashliwal here, and I think he'll agree with me that more than 50% of times, the first manifestation of coronary artery disease is an acute cardiac event. That is the first presentation of the cardiovascular disease. And it comes unannounced. You remember KK, 50 years old, died suddenly, comes unannounced. And as you would see, just about 2 weeks ago, there was the Times of India article, why heart attacks are striking gym goers in their 30s, 40s, and 50s. You expect that these will be the healthy living people. Why would the young people really be dying of heart attacks? And as we all know, and this is the study which Dr. Prabhakaran did in India, the million death studies, and then the global burden of disease studies. Cardiovascular diseases cause more than 2.1 million deaths in India, almost a tenth of all the deaths that occur across the world. And that was in 2015. Coronary artery disease being the most predominant cause as compared to only 1.4 million deaths in 2004. So in about 10 years' time, there was a 50% increase in the cardiovascular diseases. And the number is higher than the global average of 235 over 100,000. While the high-income countries have experienced remarkable declines in the coronary artery disease mortality globally, since 1980s, India has shown increasing trends. The coronary artery disease mortality rates in rural areas have increased rapidly and surpassed urban rates, a reversal of the traditional patterns, and highlights the epidemic spread to previously lower risk populations. And it occurs at a much younger age. As you can see here, that this outstanding inter-heart study, the first myocardial infarction, the mean age was approximately 5 years younger as compared to the other parts of the world in South Asia. Not only that, the percent of the MIs that occur under the age of 40 years has been double of those in the other countries in South Asia. Not only here, wherever you go in the world, you see that the coronary artery disease comes unexpected. President Clinton, 1992, he's taking over as the president of the country. And at that point in time, obviously, once the president is taking over, you take them for a thorough medical examination. And as you would see here, that he's doing perfectly fine at that point in time. He was put to the treadmill test. He went to stage 5, almost at the athletic proportions. 91% of the maximum targeted heart rate achieved, and doctors stopped it. Not that he was tired or he had any symptoms. And once you have a stress test which is negative, we always give a certificate of immortality to the patient. And with that, he started his presidency every single year, exceeding the treadmill test stage, Bruce stage 5, suggesting thereby that he has no coronary artery disease, or at least he does not have a obstructive coronary artery disease, no symptoms, no obstructive coronary artery disease because the treadmill test is normal. 1999, look at his cholesterol profile, total cholesterol of 196, LDL of 130, normal for those days. We don't consider it normal. And as you know that the lipid guidelines have come today, the revised guidelines of 2026, they have arrived today. And the numbers are much lower. But at that time, it was normal. And now 2001, he's relinquishing his presidency, leaving. And at that time, the cholesterol and LDL both have jumped about 40 points. I don't know whether he was on statins or he was not on statins. And after that, there is no information in the public domain as he was not the president. And in September of 2004, he was diagnosed with heart attack and required an emergency quadruple bypass surgery. Why is it that somebody who continuously has the normal stress test, does not have any symptoms, would present with heart attack? And this was the study that we started when I was still in New York about 5 years ago. And as you would see, that these are the 500 first-time myocardial infarctions. And 53% developed the symptoms only on the day of acute event, no symptoms earlier. And these individuals had, obviously, advanced plaques that the traditional tools never detected. So most first-time myocardial infarction patients are asymptomatic, a complete mismatch between the guideline tools and the real disease. And the message is clear. The message is that we need to detect the disease, not predict the disease. The risk calculators are the population tools. The symptoms and the stress tests are the late markers of the disease, and none identify early coronary artery disease in an individual. So we need to find Waldos. And how do we do that? The onus is on us to find out who will live without events and who will die of preventable events and when. Unless we do that, we will not be able to achieve the world where the coronary artery disease is rare. So, why does it all happen? Some of the very illuminating studies, such as those which are coming from Dr. Michael Davies in London, you would see on the right-hand panel that there is a plaque rupture. And you will see that the lumen is not significantly occluded here. It would not have caused chest pain. It would not have resulted in the positive stress test. On the other hand, if you will look at the stable plaque, it looks very different. And if I show you the histology of those, here are 3 patients who died suddenly. On the left-hand side, you will see that there is a significantly huge plaque. There is a large necrotic core. There is a thin fibrous cap, and that cap has ruptured at the thinnest site, and the necrotic core, which is thrombogenic, has been exposed to the blood. A thrombus has formed, and that has resulted in an acute coronary event. The same thing is happening on the right upper hand. You have got a huge necrotic core here. You've got a thin fibrous cap. It ruptures here and results in a clot. Similarly, here. So all 3 have same pathological signature. They have huge necrotic cores, full of cholesterol crystals and the lipid core. They have got very thin fibrous cap, which obviously gives way when there is any significant hemodynamic perturbation, for example, even during exercise, as we saw 30, 40, and 50 years old people. Now, they are significantly inflamed fibrous caps. So, in all 3, the pathological signatures are same. What is the difference in 3 plaques? In this the lumen is modestly occluded. In this, the lumen is not occluded. And in this, the lumen is critically occluded. They all resulted in an acute coronary event. These two, the one on the top and on the left-hand panel, they would not have resulted in the chest pain before the event. Even if you did the stress test, it would have been normal. Only the third one here would have shown you a positive test, or he must have complained of chest pain. Why does that happen? Why is it that you have such huge necrotic cores, such as this? They exist, and you still do not have the luminal occlusion. And that is something that we call as Glegov's phenomenon, that when there is a lipid deposition in the artery, first there is an expansion of the artery outwards rather than inwards, something what we call as positive remodeling, something which I always demonstrate by comparing George Orson Welles with Claudia Schiffer. If you look at the deposition of fat, it expands outwards. Absence of the fat, you go inward, or the negative remodeling. In the other one, it is a positive remodeling. And that results in an acute event without causing the symptoms or stress ischemia. Now let's presume that you have got the same plaque pathology, but the plaque has still not ruptured. Can we call these plaques as plaques which are at high risk of rupture, or plaques which are vulnerable to rupture? So you will see the similar disposition here, that you have one with the modest occlusion of the lumen, no occlusion of the lumen, and critical occlusion of the lumen. But they all have these similar characteristics, and they are at risk of rupture. All of them are sitting at a ticking time bomb. Now, can we identify that? We started doing this in 2003. People used to laugh at us when we used to say that we will be able to identify that by doing a CT angiography. And what we demonstrated, or what we found, was that there were two important features in the plaques that would result in an acute event. One was the positive remodeling. If you remember the George Orson Welles abdominal girth here. And the second important thing was the low attenuation or low density plaques, which is the deposition of lipid. Compare that to the stable plaque. Here it is 99% occlusive plaque, but there is a negative remodeling. You can see a waist here, or the Claudia Schiffer type of a lesion in this particular case. And we demonstrated that upon following 1,000 cases for 2 years, there was 22.5% likelihood of having an event if we had the lesion like this. If we had a lesion like this, there was only about 0.5% chance of having an acute event over the next 2 years, giving us a 45 times hazard ratio. We thought we have found the answer, and that we will be able to identify these lesions very easily. But the nature is not so simple. There is a lot of complexity here. Here is 3,000 subjects followed for 10 years. High-risk plaques are high-risk plaques. They are 10-fold higher likelihood of having an event as compared to non-high-risk plaques. However, the non-high-risk plaques, which do not result in an acute event for 2 years, gradually some of them also start to progress over a period of time. And as you would see here, that only those plaques rupture which progress over a period of time. If you are able to stop the progression, you will be able to stop them from having an event. So, where comes the catch? The catch is that at any given time, 90% of the plaques are stable plaques. Only about 10% of the plaques are high-risk plaques. So even if there is 10-fold higher likelihood of having an event of a high-risk plaque as compared to the non-high-risk plaque, at the end of 10 years, you have 50% of the events which are occurring from the high-risk plaques as compared to those which are the non-high-risk plaques. So 50% from there and 50% there. So we are back to square one. So now, we are, after looking at multiple of these cases, we have now started to find which plaques are likely to progress and which plaques are not likely to progress, and we will be able to project it by doing these are all the machine learning assessments here. We will be able to identify as to which plaque is likely to result in an event if we do not change the therapeutic intervention, or if we do not try to curb the progression of these plaques. Until we do that, why not do something extremely simple? And that is that let us be more vigilant about identifying the risk factors. Now, I apologize here that there is no mass LD in this particular thing, which we must start adding. And even in today's guidelines, I have not fully reviewed them. This was approximately 200 pages. But whatever I could skim, I don't think they have particularly mentioned. They talk about CKM, but there has been no particular mention about the MASLD when I was trying to look at that. But this inter-heart study, one of the finest studies of our time, having been done by Dr. Salim Yusuf, the son of the soil. And as you would see here, 27,000 subjects, 52 countries here. And there are some risk factors here, and there are some protective risk factors on that side. And you'll see, let us just focus on one simple thing, which is hyperlipidemia, that there is approximately 50% population attributable risk of having the hypercholesterolemia in this particular case. And it is approximately 90% plus population attributable risk if we have a knowledge of all 9 risk factors. Not only that, as the LDL increases, here are in deciles, there will be an increase in the odds ratio of having an event, which remains the same, whichever country we go to or whichever continent we are in, be in Europe, America, China, Asia, or wherever else. And if we come back to the death which was occurring during the exercise, those people who developed the exercise, we found that they also had the similarly high-risk plaques, they had much higher cholesterol level, and they all had the vulnerable plaques. And another important thing that you will see, which comes from the inter-heart study here, that the acute myocardial infarction probability and having the myocardial infarction earlier than 40 years of age remains significantly greater in the South Asians. However, when you normalize them for the risk factors, the likelihood becomes the same. So, it is all about the risk factors. Now, not only what we are seeing here, even we go 4,000 years ago. We started with a hypothesis that the subjects in those days, 4,000 years ago or 3,000 years ago, at that time they lived a much better life. And they should not have had coronary artery disease. So we thought that if we subject them to the coronary artery or the vascular calcification studies, we will be able to identify whether they had diseases or they did not. So we ended up in Egypt, did about 200 of the mummies that we imaged, hoping that we will not find the arterial or vascular calcification in those cases. But what we found was unexpected. You will see that there is a significant coronary artery calcification, significant calcification of the iliofemoral arteries here. And then we thought that there is some problem here. But we ended up talking to the various mummy scientists there, like Dr. Zahi Hawass and Nuruddin Ahmed and others, and we were told that they were carried in palanquins, they were all elites, and they had access to all kind of food. They used to consume food 3 to 5 times a day, and a rich food. And essentially, they had everything at that time, which we have today. So we thought that we were looking at a wrong population. We ended up in Peru, where the people around in the foothills of the Andes mountain, these are the farmers, their naturally mummified remains are available. We did about 200 of those mummies as well. And as you would see, that they were put into the knee-elbow position when they were dead, essentially putting them into this position because they have to return to the afterworld, same way as they came to this world. And so some of those which we found, we thought that these were the better mummies that we had, because they are farmers, they are manual laborers, they go up and down the mountain. 50% of them are vegetarians, 50% of them consume alpaca, which is a much leaner meat. So we thought that we have found the right population. However, when you look at it, you find that there is a significant calcification in less number of cases, but still there was significant calcification, and we did not understand what exactly was going on. On one hand, we felt good also that, okay, you know, do whatever you want to do. You are doomed. You have got to get the coronary artery disease or vascular disease. Let's do whatever we can. But then, when we did some of the autopsies in these cases, we found out that those who had atherosclerosis also had black lungs, predominantly in women, younger women, where you do not want to see the disease, or where you normally do not get the disease. And then we ended up going to those homes where actually found out that they were low-ceiling homes. Women used to cook in there, and they would be exposed to the smoke. So there is still a risk factor. And not only that, look at all the low and middle income countries. What are women exposed to? Not only that, look at what the children are exposed to who are in their laps or who are clinging onto their legs here. So we ended up then to look at one of the tribal areas in Bolivian jungles. Now these are Amazonian jungles, and this tribe, which is the Chimane tribe, that lives along the river Manuki. We were told that this is not a genetically blue zone, but the people live there for very long. So we have done about 750 scans in those Chimane people, and we have done about 3,500 carotid ultrasounds in those. Dr. Kasliwal, you would love that. Now, these are the people who are along this river. As you can see, they live in open huts like this. There is no pollution. They don't smoke. And they fish by just bow and arrow, or they eat monkeys, jaguars, or pigs. There are some wild fruits available, some wild maize available, plantains are available in those, but they eat only once a day. They prepare the meat, as you can see here, and it cooks on a slow fire, and they prepare the stew, and they consume it. Whole day they walk because they have to find the prey. And look at the people here. This is one of my most favorite couple, 99 years old woman with her 85 years old husband. They had come for cataract surgery. They had 0 calcium artery score. Right? So, why do they live so long? Most of these people have lived to 80 years, 90 years, 100 years. And why do they do so? Because their LDL is always less than 70, their blood pressure less than 120, sugar less than 80, BMI is less than 24, 15 to 20,000 steps a day, no pollution, no coronary artery calcium. Compare them to any other population in the world. They look at, by the 80 years, what happens? Look at United States. What is the level of their calcium? And this population, there is essentially, whether they are women or they are men, there is nothing that happens to them. And when the paper was published in Lancet, there was 2 back-to-back coverage, full-page coverage in the New York Times there, that heart healthy in Amazon, or we must learn from our patients' heart health mistakes. So, ladies and gentlemen, 70 LDL there. All the animals in the world have total cholesterol which is less than 100. There is one animal which is proud of 200 cholesterol. And that is human. Not only that, look at the LDL and HDL profiles there, electrophoretic patterns there. All the animals have HDL which is greater than LDL because they are born with 25 LDL and HDL of 45. We are also born with HDL of 45. We have 45 of HDL, but I'm finishing. I know Prabhakar is walking. So look at the LDL. Their LDLs are 25, HDL of 45. And look at the human, HDL has increased. There is one other animal, and that is pig. which has LDL, which is same, their HDL falls down because, as Dr. Sareen was talking earlier, they don't move at all or who do not want to move. So their HDL goes down. We are all born with 25 LDL. Dr. Salim Yusuf's study again. In about 3 years' time, their LDL goes to 130. What do we do? So we proposed that it is because of the consumption of sugar, and I don't want to go into the story how we found out what the molecular mechanisms are, but we wanted to actually demonstrate that. And the only way we could do that, because the randomized study was not allowed to us. Looking at the UK Biobank here. Look at the UK Biobank, the challenge was they need the random exposure to sugar-rich diet early in life with outcomes measured decades later. So there are approximately 28,000 subjects here, or 28,000 children here, and which were looked upon that the sugar rationing after the World War II ended in the United Kingdom on 23rd September 1953. So looked at children born 1,000 days before and children born 1,000 days after. Compare those, because suddenly on 23rd of September, you'll see that the sugar consumption more than doubled up. And the proteins produced and all other things remained the same. And look at what happened to the 40 years later to the diabetes. There is a significant increase in diabetes. There is a significant increase in hypertension. So significantly increased hypertension, diabetes, significant jump in cholesterol as we had expected. These data are still not published. Significant increase in the inflammation, increase in cardiovascular disease, myocardial infarction, the MI mortality, and the stroke mortality in these cases. So as the cholesterol burden increases, there is an increase in the likelihood of having a coronary disease. And the reverse is also true, that as you bring down the level of LDL cholesterol, the likelihood of having a major adverse cardiac event also decreases. And as you will see here, that if I extrapolate it for primary prevention at 55, you basically have a zero event. And today's guidelines tell you that you should bring, at least for the secondary prevention, you should bring down your LDL to 55. I think it is still high. On the other hand, when you look at the secondary prevention, you will get a zero cardiovascular mortality if the LDL is 30. So, as Dr. Braunwald proposes, what if we started to give the inclisiran to everybody at the age of 35? Would we be able to bring down the LDL level to 50 so that the threshold for the atherosclerotic cardiovascular disease would increase to the year 100, and you will be able to live to 100 without having an event? So the last two slides, Prabhakarji, I know you have started to walk again towards me. And the WHF in two major projects that it is going ahead with. One is towards the Cardio 4 City Accelerator, where we are trying to look at the precision population health here, because there is no one side that fits all approach to improve the cardiovascular health. Every population is susceptible to different risk enhancers based on where they live and their lifestyles, and we can really target our population-based approach to a precision, and we can really impact the population health. And the last slide here, that we have also proposed the City Heartbeat Index, where we want to start a kind of a competition between the cities. And the first report actually arrived yesterday in the Nature Reviews Cardiology. And we looked at the 50 metropolises from across the world based on 45 determinants from those cities, and we numbered them quite like you have the US News and World Report, hoping that we will be able to identify by the precision population health, by the digital data, what exactly needs to be done to these places. So can we really bring our risk factors in a collective approach down to a level where we will be able to make the world where the coronary artery disease is rare. Thank you.
Thank you, Professor Narula, for your excellent super speech. Can you have a seat over here? Thank you very much for illuminating on the issue as usual. And I have heard best of best, lectures on this subject. You have shown the Bolivian Amazon pattern. So we have to go to those patterns to get our LDL cholesterol down, to have 10,000 plus steps. And they're telling now that 7,000 steps above the age of 60 is enough. So anyhow,
Professor Jagat Narula, there is a very enlightening session. And I think this is very relevant to our Asian community, because I think, if I remember correct, 2024, the number of cardiometabolic disease burden was close to about 4.8 billion. So in a country like India, where you're talking about pollution, and being in cardiology for the last 35 years, we tend to see a lot of young people at the age of 30. I'm sure Dr. Kahali will also agree. 30 years, 35 years, coming with the first-time MI. The 53% of them, the message was, it's the first time that you get to know is when you have an MI. So why is this happening? So the question always comes to the back of our minds. Most of our people from the lower socioeconomic class have something like 160 cholesterol, 100 LDL. But the point is, I think you need to be really aggressive, and also from what we have gathered over the last few hours, we perhaps have to look into the cardio. It's not just CKM, cardio, hepato, renal, metabolic. This is probably the way to think about. And I'm sure inclisiran probably might be a game changer in terms of bringing. You cannot bring down the LDL to whatever level that you are talking about just with the statins and the other combination medicines. So I think this is a real key message which has come out of it. We really have to assess everyone. I think some of us sitting here may be harboring this disease, thinking under the false pretext of being normal. I think a day has come where all of us should look into your own profiles. In fact, we did a study from Kerala where we found the doctors are the worst kind of patients. They never even bothered to look at their cholesterol. So I think it's a very relevant thing for our community. And thank you so much for your brilliant presentation.
I think the early screening for young individuals is the solution, because we have gone to hundreds of such patients who come at the age of 31. Recently, I have done a proximal LAD 99% lesion in a 31-year-old lady, normal habitat, but she had a strong family history and she is a diabetic. And her cholesterol was little high, 200 around. And we did the plasty successfully, and we did the full screening of the family. Many had diabetes, many had, this elevated cholesterol. So we have to go for early screening of these individuals. And not only that, with a positive family history of hypercholesterolemia, we have to go for early screening at the age of 2 to diagnose the familial homozygous hypercholesterolemia and also heterozygous hypercholesterolemia, though the onset and the presentation is at a later stage in the 3rd decade or 4th decade. But I saw recently all the, signs of xanthelasma, everything, hypercholesterolemia was there. The lady presented with acute coronary syndrome, 40 kg weight, 41-year-old, and the patient's cholesterol was only 677, LDL cholesterol 627. And then he discontinued the drugs after successfully opening the right coronary artery in the acute infarct. And next day I didn't lose any time. Next morning I opened the left coronary, left main coronary artery ostium and left main bifurcation. It's a long lesion. And the patient came to me after a month and she told that she has stopped all the drugs for the last 15 days. Fortunately, all the stents were okay. Thanks God.
I would like to add something else there. And you are so right about the screening and timely and appropriate screening here. But there are two important things that I do in my clinic. One is that there is a big board outside my clinic where I have asked people to come to me 10 years before their father died of heart attack, or they had their coronary bypass surgery or the angioplasty. Give me 10 years and I'll take care of you, hoping that they are going to have the event at the same point in time. And the second, my clinic at least has 50% of the patients who are perimenopausal women. because in women, the disease starts with vengeance at the time of menopause. As I have always said, that God protects them till menopause. After that, they become useless to the world because they are not able to produce, right? And people often ask me, what about males? And I tell them that they are useless from day one. So, so essentially, these are the two most important parameters which I use for bringing the patients into the clinic.
So from the Cardiological Society of India, we have going to the schools and preaching all this to the small students so that their, guardians, their neighbors, their teachers also are coming. We are having separate sessions with the, teachers also. We are trying to penetrate and educate them so that we believe in primordial prevention, primary prevention, and not to tell of secondary prevention. That's the way in early screening. And all the patients at this young age, we used to tell it appears 1 decade earlier, 1.5 decade earlier, maybe 2 decades earlier. 31 is 2 decades earlier. But actually, all the patients has got 95% plus patients has got a definite one or more risk factors, usually more than one risk factor. And so if we can screen them early, we can prevent them disease. I think it's high time that we should not only tell that the patients in our country will get very early disease. We have to prevent it, and the onus is each one of us, and we have to prevent it seriously by going into the root cause of the disease and preventing it effectively. And also another thing, sir, in our country, the patients after a heart attack goes to the, said hospital after a long time. Not even, I don't agree about 5 years and 6 years in your Kerala registry and create registry. What we get in practical life, many a times after 12 hours or 18 hours or even 24 hours.
No, but that has changed quite a lot in
Yeah,
Kerala. I mean, that's, I think, beyond the scope of this discussion.
No, but what I want to tell, that these are the two lacunae which we have got in our society, and, we can prevent billions of rupees at least by going in deep into these causes. Thank
Just a
you,
final comment, for maybe perhaps a India-specific prediction score is the need of the hour. Yeah, thank you.